So chapter 20 is about the heart, and these are the learning outcomes. We're going to talk about the anatomy of the heart, the electricity of the heart, the mechanics of the heart, the cardiac cycle, how the blood rotates in the different chambers, which is oxygenated, which is deoxygenated, and other things. So when we say cardiovascular system, generally speaking, cardio means heart, vascular means vessels. So we're talking about the heart and the blood vessels. That's the system. And the blood runs within that system, but we covered the blood already. So our focus will be heart and blood vessels. Um, so this is if you multiply the beats per day, which is okay to know. 100,000 per day, 8,000 liters. But the circuits will be two circuits, two pathways of the blood leaving and coming back to the heart. The first one is called the pulmonary circuit. Simply, this is between the heart and the lung. Blood leave the heart and go to the lung, and then from the lung back to the heart. This is called pulmonary circuit. Systemic circuit, on the other hand, blood leave the heart, go to every part of the body, not the lung, everything else, and then come back. We call that the systemic circuit. We have a model like this in the lab, if you guys remember. You might see it in the lab with a couple of questions only, but um, this is something that we need to know. We are starting with the heart itself. So if you look here, just to understand the system, remember when we talked about the inferior vena cava bringing the deoxygenated blood from the lower part of the body? You see this blue? And pour it into the right atrium. Superior vena cava up there, bring the blood from the upper part of the body, the part that's above the heart, and bring it also to the right atrium. So deoxygenated blood is collecting into the right atrium via two sources so far, but there is a third source. What is it? Deoxygenated blood coming to the right atrium through superior vena cava, inferior vena cava, and there is a third one, not the pulmonary artery, bringing the oxygenated blood to the right atrium. Yes, start with C. C-O-R, not carotid. Coronary sinus. Coronary. I showed you guys this in the lab. Do you remember when you opened the right atrium and there was an oval fossa ovalis and there was an opening beside it? Do you guys remember this? This is the coronary sinus. So three sources, not two. Superior vena cava and inferior vena cava, these are the big ones that you cannot miss. But there is a third one, bringing deoxygenated blood from the heart itself. Like superior vena cava, everything above the heart. Inferior vena cava, from everything under the heart. How about the heart itself? The heart get oxygenated blood, and then the oxygenated blood leave the heart tissues itself, the muscles. Where does it go? Same thing, right atrium. And then from the right atrium, see it's blue, deoxygenated from the three sources. It passes through the right AV valve or tricuspid valve to the right ventricle, and then it's going to be pumped into the pulmonary trunk, pulmonary arteries, right and left. So now, starting from the pulmonary semilunar valve, after passing this is the pulmonary circuit. Right ventricle, pulmonary semilunar valve, to the pulmonary trunk, right and left pulmonary arteries, to the right and left lungs. That's set for the deoxygenated. Over there in the lung, it will be oxygenated. When you breathe, you get rid of carbon dioxide and you gain oxygen, right? So the next part, still pulmonary circuit, will be this red, that the blood is coming back from the lungs back to the heart through pulmonary veins. And I talked about that in the lab. I told you the definition of artery is the vessel that take the blood away from the heart, not necessarily oxygenated. It is 90 something percent oxygenated, but this is not the definition. The definition is all about the direction of the blood flow. If it is the blood, a vessel taking the blood away from the heart, you call it an artery. Usually, all of these arteries are red. Look at all of these. But how about this one? Pulmonary, trunk and pulmonary arteries, deoxygenated. That's okay because it's all about the direction of the blood flow. Now the veins, all these veins, look at everything blue in this picture. All of these are veins. So veins carry the oxygenated blood. Well, this is not the definition. It happened that most of them are, but this vein is carrying oxygenated blood. And that's why I keep on saying when you see the word pulmonary, reverse what you remember. You always remember artery is red, veins are blue, right? We always remember that. When you hear pulmonary, it's the opposite. So pulmonary veins are going to take the blood back to the left atrium through the left AV valve or bicuspid valve, or what's the third name? What's the third name for the left? The bicuspid. There is a third name, and I told you guys to remember the three names. And it is in a critical thinking question that I put for you. What is it? It starts with M. Mitral. Yes. It's also called the mitral valve. So mitral valve, through the mitral valve, passing to the left ventricle pumping it out through the aortic semilunar valve to the aorta, ascending, arch, descending. And there are arteries from there that will distribute it all over the body. So this is like kind of reviewing the circulation that we talked about. Now, again, the definition is artery is what the blood vessel that take the blood away from the heart. Vein is what the vessel that return the blood back to the heart. And capillaries are also called exchange vessels. This is in between. So arteries take the blood away from the heart. It divide like a tree. Divide like a tree. And then there are capillaries and then veins. So between arteries and veins, the smallest are the capillaries. There is another name for each one of those that you have to know. Capillaries are called exchange vessels. Why? Because at any other level, blood does not leave the vessels, cannot. There are no openings. It cannot leave or come back. There is no way. The only way for anything in the blood to leave or come back is when you have openings. And openings are only in the capillaries. And that's why we call it the exchange vessels, because from these, oxygen and carbon dioxide and nutrients, they can leave the blood. And carbon dioxide and waste products can come back. So this is the only spot in the whole tree of blood vessels that exchange can occur because of the openings in the capillaries. And I'm telling you right now, you have to know the other name for each one of those. We started with this, exchange vessels. And you will see the rest coming. No, it's just carry. It's just a carrier of the blood. No openings. So now the chambers of the heart. This was in the lab. We have right atrium receiving the oxygenated blood from the three sources, followed by the followed by the right ventricle, out to the lung, coming back from the lung to the left atrium to the left ventricle. These are the four chambers of the heart. When you look at the heart, it looks like a pyramidal shape, kind of. So there is a base and apex. The base is up here. This is where the great blood vessels are located. Do you guys remember this? How the heart looks like this? Like pointing down like this. This upper part from which the major blood vessels are located, we call it the base. And this pointing down a little bit more to the left. It's not going down like this. It goes to the left. This is called the apex of the heart. And the heart is located, the space of the heart, this is AP1. Remember, you have right pulmonary and left pulmonary cavities, and then in between is called the mediastinum. This is where a location is. So here it is, the heart is located in the middle between lung that's located in the right pulmonary cavity and the left lung in the left pulmonary cavity. This is located where? Located in the mediastinum. Look at the base. This part up here, all these blood vessels are in the base. Look at this. This is the apex. It's pointing down and to the left, not just down. The diaphragm is under all of this. Um, Surrounding the heart, just like surrounding many other organs, there are always two layers covering the heart, two layers covering the lung, which are serous membrane, two serous membranes. It will be the same thing in a digestive system and reproductive system, same thing. Um, these are serous membranes. What's a serous membrane? A membrane that secretes serous fluid. What's a serous fluid? Like serum, like watery secretion. The name comes from the secretions. In between the two layers, there is serous secretion. And I always say that those two layers are exactly like this. You go to a supermarket, okay, and you're buying some groceries, okay? And if these groceries are heavy, you tell them like double the bags, right? Put it in two bags. So if you put like watermelon inside a bag, and there is another bag. Now, what's outside the watermelon? Two bags. One of them is inside, in contact with the watermelon, and additional one outside. That's exactly what it is. So the inner one that's in contact with the heart, just like the inner bag, in contact with the watermelon, this is called the visceral pericardium. The outer, the double bag, the next one outside, is called the parietal layer, like the outer bag. Together, these are called, together, this is called the serous pericardium. In between those two layers, like the two bags that you're carrying, there is a space, but in this case, it's not a space. It contains fluid. And this is the serous fluid I was talking about. We call it pericardial cavity and pericardial fluid running in this cavity for a reason. What is that reason? If you're carrying something, some groceries in two bags, there is a space in between, right? That's okay. But for the heart and lung and abdomen, that's not okay. Why? Because the heart, the inner layer, the visceral layer, is adherent to the heart, and the outer layer is adherent to the outside. If there is nothing in between, they will separate. You cannot allow that to separate. They have to stay together. And in order to keep them together, you put a thin layer of fluid in between, just like if you get two flat pieces of glass and you put some water and put it like this, they will stick, right? Did you ever try this? Did you see it? If you put two flat glasses and put some water, they will stick, and they will stick hard, actually. So that's what's happening because those two layers should not separate. In case of the heart, in case of the lung, same thing. There has to be some fluid in between, keeping them. So here is the heart, and these are the two layers. Visceral one is actually adherent to the heart, and the parietal one is more outside. And there is fluid in between. It's called the pericardial cavity, and there is serous fluid in between. So here it is again, as if you're pushing a balloon. So there will be one layer that's adherent or touching your hand, and the other one is more outside, and there is a space in between, like this, the visceral layer of the serous pericardium, the parietal layer of the serous pericardium is outside, and in between pericardial cavity containing the fluid, the serous fluid. Um, if an inflammation or infection occur to that pericardium, it's called pericarditis. And obviously, when you put itis at the end of any word, it means inflammation or infection. inflammation or infection. Okay? And if that's the case, if fluid accumulated in between the two layers, it will be pushing the heart, compressing the heart, and this can lead to an issue with the heart dilating. We call it cardiac tamponade, but that's okay. The wall of the atrium is completely different than the wall of the ventricle. If you notice that in the lab, the atria have very thin wall. The ventricles are thicker. But did you notice the difference between right ventricle and left ventricle? Is the wall same or one of them is thicker than the other? Left, it's thicker, right? So both ventricles are thick, both atria are thin. But those two ventricles that are thick, one is thicker than the other for a reason that you need to know. So why is the atria have this thin wall? It's all about your needs. If you need effort, if you need power, you need more muscles, right? It's common sense. If you need less, if you don't if your effort is not that much, if you don't need much effort, you don't need much muscles. And basically, the blood up there in the atria just need to go down to the ventricles. What kind of effort do you need, right? It's minimum. Just goes down, just push it a little bit. No much effort needed. That's why it's thin. Ventricles, they need to pump the blood out of the heart. So it has to be thicker. However, the left side is pumping the blood to the whole entire body, down all the way to your feet and up to your head. So it has to be very strong in order to push the blood all this distance. On the other hand, the right ventricle is just pushing the blood up to the lung. And where is the lung? It's right beside the heart, isn't it? Surrounding the heart. So you do need some effort because you're moving out, but it's not that big of a distance. So that explains it. And in between um, the two atria, there is a septum separating them. It should be closed. There is nothing. There are no openings after we're born. Before that, there was an opening in the atrium, but we will talk about it later. But for now, if we're talking about our heart, the regular heart, the interventricular septum is compact. It's closed. Nothing in there. Same thing for the atria. There is something called sulcus, and sulcus means a depression. Okay, a linear depression. There is a depression in which the blood vessels. Do you remember this coronary circulation that was hard, right? Coronary artery and marginal and all these things, right? It's all located in a sulcus. Why? Because if you just leave it on the surface of the heart, it's easy to be injured. But if you keep it in a sulcus and cover it with some fat, it's very protected, isn't it? If you put it here, it can be injured. But if I put it down here in a sulcus and cover it, it's protected, right? So all these coronary blood vessels are located inside sulci. So there is one sulcus, circular one, separating the two atria on top and two ventricles. Do you remember this? There was a sulcus in between, a depression in between, the two atria above and the two ventricles down. So this is called the coronary sulcus. There is another one between the two ventricles. Do you remember the anterior interventricular artery located in a sulcus, right? It's the sulcus in between the two ventricles. In between or between is enter, right? Which is different than intra. Enter is in between, intra is inside. Okay, this is just medical terminology. So interventricular sulcus, the sulcus that's in between the two ventricles, right and left. There is one in the front, anterior, and one in the back, posterior. Here is the heart. The base is up here, and it is like at this level, like at rep number 1. And look at the apex. It's about in between 4 and 5 reps. And see how it is more pushed to the left side. Did you notice this? Look, this is the sternum. The sternum is exactly in the middle. You remember the bones? Sternum is exactly in the middle, right here. And look at this part of the heart versus this. It's obviously pushed to the left. And that will explain later why left lung is different than the right lung because of this. Right atrium with the right auricle here. Left atrium, you don't see it, but you see the left auricle. Right ventricle, left ventricle. Look at this. Do you see this yellow? This yellow is fat in the sulcus. So this is coronary sulcus right here in between the atria and the ventricles. And look at this one. This is the anterior interventricular sulcus. If you rotate in the back, you will see the posterior interventricular sulcus. And actually, in our body, the blood vessels are inside these sulci and covered by fat. When we do the gross anatomy uh, at the School of Dentistry, we actually do this dissection. In order to see, we remove the fat. All of us. You have to have fat covering the sulcus. The sulcus is in there, the artery or the vein is inside, and then it's covered by fat. So this is healthy fat. It's not bad fat. It act as a cushion, it protect, and so on. Look at this. The fat was removed in order to show you this. And here you will see right coronary artery, right marginal, and in the back, posterior interventricular. Here you will see the left coronary, anterior interventricular, and the circumflex in the back, and so on. This is how it actually looks like. This is an actual picture, but the pericardium was removed. So you see actual muscles here. So this is the pulmonary trunk, the pulmonary arteries. This is the aorta, ascending, transverse or arch, brachiocephalic trunk, left common carotid, left subclavian, and so on. If you're looking in the back, you will see this posterior interventricular sulcus. How to know that this is the back, not the front? Left atrium is in the back, not really in the left. You saw the heart, right? It's not like this. It's not flat. It's not like right atrium, right ventricle, left ventricle. It's not like that, right? It's rotated. So the left atrium is in the back. So when you see the left atrium like this, the only thing that you can see from the front is barely part of the auricle. That's it. You don't see the actual atrium. It's all the way in the back. So if you see the atrium here, you're looking at the back. And this sulcus here, including the posterior interventricular artery and the middle cardiac vein, this is the back, the posterior interventricular. And this is the trick to know them. It's not that easy to tell from the beginning, but I'm giving you tips. If you look at it from the front, you will see the pulmonary trunk right here, and you barely see the auricles. So you know this is anterior. Versus this, you actually see the big part of the right atrium, and you see the whole entire left atrium. So you're looking in the back. Since you're looking in the back, which is posterior, this is posterior interventricular. Um, Now remember those two: visceral pericardium, the inner one, adherent to the heart, and the parietal that's outside. The visceral, we counted toward the layers of the heart itself. So we also call it epicardium. Does it count toward the heart itself, or does it count toward the pericardium? Both of them. Both of them. It is the outermost of the heart, and it's the inner layer of the pericardium. So it is serving two purposes. It's both at the same time. And that's why we call it epicardium. You will see the layers of the wall of the heart, and you will see that this is the outermost. So it is both of them. It is the outermost of the heart wall and the visceral pericardium at the same time. So if this is the epicardium, the middle layer will be of the wall of the heart, which actually contain the muscles. So this is the big one. The thick one is called myocardium. And myocardium, myo is a prefix that means muscles. Okay? And it should remind you with metal. Both of them start with M. Okay? The inner one is called endocardium. And if you know what's endo and what's myo and what's epi, you get it. Endo means inside, innermost, endo. Myo, muscle, it's middle. Epi means surrounding or outermost. The outermost is connective tissue. The myocardium, the name give it away. It's called myo. Myo means muscles. And the endocardium is endothelium. It has to be endothelium because endothelium is smooth. So the blood is inside the heart would be in contact with this smooth layer. Look at this picture right here. This is the endothelium all the way inside. This endothelium is flat, smooth, so the blood will be in contact with this. The outside is connective tissue. Look in the middle, cardiac muscles, all of this. So this is the main chunk of the wall. The muscles are arranged in different directions to make sure that when you squeeze, when you contract all these muscles, it's push most of the blood out. So it's there in a way that's a spiral way in order to make sure it's like an eight figure around the atria like this. If you draw like eight, this is how it's arranged around the atria. There is connective tissue like the epicardium that I just talked about. This is connective tissue. The pericardium is connective tissue. There is other connective tissue, and connective tissue is there for, and this is an important piece of information, it's there for restriction. It restricts the dilation of the heart. So when the blood comes to the heart dilates, right? Like when you put water in the balloon dilates, right? Stretch. So how much stretching do we allow? It should be limited. Otherwise, if you put too much blood, like if somebody having hypertension, for example, you put a lot of blood under pressure, and if there is no restriction, it can rupture. So in order to restrict and avoid overexpansion, you have to have this connective tissue restricting and surrounding and restricting the heart. There is also a cardiac skeleton, which is another connective tissue, and this is more for stabilization and to keep the valves in place. Septa, I talked about it. The septum in between the two atria is called interatrial septum. And again, please, medical terminology, I keep on saying that. Inter is not intra. Inter is in between. Interatrial, in between the two atria. Intra-atrial, inside the atrium. We're not talking about intra, it's enter. So interatrial septum, the septum between the two atria. Interventricular septum, the septum between the two ventricles, and this is a thicker one, unlike the atrial one. And again, there are no openings or defects or anything, except for fetus. We will talk about this. But at birth, we're born with a complete septum that's completely separating right and left. If it is not, this will be an issue. Valves, AV valves, atrioventricular valves between atrium or atria and ventricles. Do you remember those? There is one in the right and one in the left. What's the other name for the one in the right? Right atrioventricular valve? What's the other name? Right. Tricuspid. Tricuspid. The right AV valve is called tricuspid. I showed you that the three cusps. Three cusps in the right side. While the left side is called bicuspid. And also called mitral valve. Three names for the left, two names for the right. All valves, generally speaking, Luxor lab, whatever the question is, they do the same function. One-way movement of the blood, preventing the opposite. You go from right atrium to right ventricle, and you don't go back. It's one-way movement, preventing the backflow. Semilunar valve, both pulmonary and aortic, both of them semilunar valve, are called semilunar valve. They do the same function. Superior and inferior vena cava, again, bringing the deoxygenated blood from the upper part of the body above the heart, inferior vena cava from under the heart into the right atrium. The right atrium, remember the fossa ovalis? Is that an opening? Fossa ovalis, is that an opening? It is not an opening. That was in the lab. Remember this oval depression? It's not an opening, right? That's why it's called fossa, not foramen. We know foramen, right? Foramen is opening. Okay, it's fossa ovalis. But in the fetus, it was an opening. It was an opening. But at the time of birth, close to birth, it's closed. And it was open for a reason. It's not a defect or something. So if I show you the heart in the lab, you never say foramen ovale. There is no opening. It's called fossa ovalis. Only in fetus. We will do the fetal circulation. There is an actual opening, and it does have a function at this time. Simply, without going into the details, because we will talk about it anyway, does the fetus breathe? Of course not, right? He takes the oxygen from the mom. And that's why he's having a different circulation. There is an opening that's called foramen ovale when it's closed. So when we're born, we should have a fossa ovalis, not foramen ovale. There is also a muscle within the wall of the atria, specifically inside the auricles. If you open the atrium and look inside the auricles, you will not see the surface flat. The surface of the atrium is flat, but look inside the auricles, you will not see the surface flat. You will see bridges. And this is called pectinate muscles. Pectinate muscles. Right? AV valve is called tricuspid valve, and we know the function. One way, preventing backflow. Clear? All of them. One way movement of the blood, preventing backflow. How does it do the job? It has cusps, whether 2 or 3, right? These cusps are attached to chorda tendons that attach to muscles. Every time when you contract, the muscles pull down on the chorda tendini, pulling down on the cusps. There is no way to reverse. If the cusps are like this, down, if you contract, if we don't have chorda tendini, look what's going to happen. These are the cusps preventing the backflow. If we don't have something pulling it down, it will reverse. And the blood goes up, which is a disease. This is an issue. But actually, it does not flip because of the chorda tendini and papillary muscle pulling it down. Look at this picture here. 1, 2, 3 cusps. Look at the white chorda tendini. And if you forgot it, chorda tendini is a cord-like tendon, or a cord that looks like tendon. Do you know the tendon, the attachment of the muscle? The white, it looks like it. It's the same nature. So it is a cord, looks like a tendon, attached to papillary muscles. And these muscles contract, pulling the chorda tendini down, pulling down the cusps. So there is no way to go back. For your information, some people who have like rheumatism or something, carditis or inflammation of the heart, they might have an issue here, and these are broken and it flips backwards. So the blood goes like from the right atrium to the right ventricle, and then part of it go back to the right atrium. And this is a big issue that needs most of the time surgical correction. Just to giving you an idea about to remember the function of these chordae tendinae. Now look at the wall of the atrium. It's very thin. Look at the wall of the ventricles. It's thick, but look at this. This is thicker than this. The left ventricle is thicker, and if I ask you about the reason, you should know, right? I'm assuming you guys know now. Now go down to the right ventricle. You will also see muscular ridges. Look at these. Do you see how this surface inside here is not flat? Do you see these ridges? Can you see this? Same thing was inside the auricles. This is flat, but the auricle is cut here. If you actually look in the lab, you will see the inside of the auricles have ridge-like muscles. Ridge-like muscles are called pectinate muscles, but the ridge-like muscles in the ventricle have another name, and it is called trabeculae carneae. One more time. Not the whole entire surface of the atrium is smooth and flat. The inside of the auricle have muscles that looks like ridge shaped, ridge-like muscles lining the inside of the auricle. Do you know the difference between auricle and atrium? Is auricle and atrium is the same thing? It is not. Auricle is outpouching. The ear-shaped auricle, ear-shaped, outpouching from the atrium, right? If you look inside of it, you will see ridge-like muscles, and we call it pectinate muscles. How about the ventricles? Same thing, but we don't call it pectinate muscles. Okay, we call it trabeculae carneae. Trabeculae carneae. One more thing here, and we'll talk about the electricity. It will make more sense, but understand it from now. You will see, look at this band right here. Look at this. Crossing. This is not part of these muscles. This is a special band. Can we see it? This one going transversely coming from here, from the septum to the wall. This special part of the muscles, it is part of the muscles, but it is a specialized part that's called moderator band. When we do the electricity, you will understand that the electricity actually runs inside this. Look, it goes in the interventricular septum, going down, going down. When it go down here, part of it will go in the moderator band and go to the papillary muscles. So we do have this specialized part that's called moderator band. It moderates the arrival of electricity into the papillary muscles. Okay, I will show you more when we get the electricity. This is how it actually looks like. This is an actual picture with the endoscope. This is how the chorda tendini looks like, and these are the papillary muscles. Remember how the electricity reached papillary muscles? Moderator band. Here it is again. These are the auricles. If you cut it open and look inside, you will see pectinate muscles. For the ventricles, it's already opened right here. Pectinate muscles. Cusps, papillary, chorda tendini, and papillary muscles. Conus arteriosus. What's the conus arteriosus? Conus arteriosus, the pulmonary trunk. Where does the pulmonary trunk arise from? From which chamber? Pulmonary trunk. Right or left? Right ventricle. It comes from the right ventricle. Do we all remember this? Pulmonary trunk from the right ventricle and then divides into the two arteries. Are we following? Okay. The pulmonary trunk is not like cylindrical shaped like this. It's not coming out of the right ventricle cylindrical shaped. No, there is a bulge first. There is a dilation that leads to it. And this dilation is called conus arteriosus. Why did you call it this name? Because it actually looks like a cone. It looks like this. Okay? This is how it arises in a cone shaped from the right ventricle and then goes like this, up. Okay? So it starts in a cone shaped, which is called conus arteriosus. This is the beginning of the pulmonary trunk arising from the right ventricle. Unlike the right atrium, what are the sources of the blood in the right atrium? Three sources: superior vena cava, inferior vena cava, and the third one is coronary sinus. Coronary sinus. The left just have 4 pulmonary veins. Are these 4 pulmonary veins bringing oxygenated or deoxygenated blood? Oxygenated. Are we following? You should know that. Okay? You will see that in the lab. Remember these critical thinking questions. You should remember this. So the blood is reaching the left atrium. Is that oxygenated or deoxygenated? Reaching the left atrium? Oxygenated. And then it will leave left atrium to the left ventricle through the bicuspid valve that has another 2 names, mitral or bicuspid or right atrioventricular. Blood go to the left ventricle, and left ventricle, where does the blood leaving the left ventricle go to? Through what? Yes, but what's carrying the blood? Aorta. Yes, it go to the aorta, right? What take the blood out of the heart from the right ventricle? If you guys are following, pulmonary trunk. What takes the blood out of the left ventricle? Aorta. And there is a valve there. What do you call the valve leading to the aorta? Aortic semilunar valve. Yes, aortic semilunar valve. Do you remember this cone-shaped beginning of the pulmonary trunk? There is something similar, but it doesn't look like a cone. It looks like this. This is called sinus. Same idea. It doesn't start, the aorta doesn't come from left ventricle like this. No, there is a dilation first that leads to the aorta. And this dilation here is called aortic sinus. So what do you call this dilated beginning of the pulmonary trunk? Conus, not medullaris. Arteriosus, conus arteriosus. And what do you call the sinus-shaped dilated part before the aorta? Aortic sinus. So from the, and by the way, aortic sinus followed by ascending aorta, arch, descending. Do you remember this? Do you remember? This sinus at the beginning that leads to the aorta, this is where the coronary arteries come from. Do you remember these coronary arteries? We have right and left. We did that in the lab. And you have a lab exam coming, right? So you should know this. Right, remember this right coronary artery give you the right marginal and the posterior interventricular, and then the left give you anterior interventricular and circumflex. Do you remember that? You'll be asked about this. You should remember. So where the right and left coronary artery come from? From the aorta. Which part of the aorta? From the sinus. Okay, so they start, both of them start from the sinus. Look at this. You see this cone shaped? Can we see this? Do you see this arrow? This cone shaped, isn't it? Kind of. It doesn't have to be exact cone. It's just going like this. Can we see this? Red, this, and this. So this is conus arteriosus. Look at this on the other hand. Look at this. I'm sorry, I mean this. Part of it is hidden here. But from here, from this part of the sinus, right coronary come. And from the other side of the sinus, left coronary come from here. So both of them come from what? From the sinus, aortic sinus. Let me ask you this question. The atrial wall is thin, isn't it? The ventricular wall is thick, but the left is thicker than the right. How about the volume? Is the volume different from right ventricle to left ventricle? What do you think?
Yeah.
How is it less? Where did it go? Like blood reaching the right atrium, all of it will go to the right ventricle. All of it will go to the lung. All of it will go to the left atrium. All of it will go to the left ventricle. Why is it different? Remember, the only way that anything can leave is the capillaries. And even in the capillaries, it's not the blood itself. The blood doesn't leave unless you have an issue. It doesn't leave. The blood is just a carrier, right? Like bus. When you go ride the bus, it will take you from this station to this station to this station, and that's it. It doesn't leave and go to your house, right? It just go from here to here to carry you. Blood is going inside a closed circuit just as a carrier. It doesn't leave. It's the same volume. It's just more pressure on the left because the wall is thicker. So what's the only difference? It's the pressure, not the volume. Do you understand the difference? There is a difference between pressure and volume. The pressure is higher because muscles are thicker, but the volume is not. The other thing that's, if you're comparing, there is one more thing. It's not just the wall is thicker and the pressure of the blood is actually thicker. This is not the only difference, but the shape is different too. Look at this. See how it is circular, round. Look at this, flat, right? This is more of flat or squeezed. It's not circular. Compare this to this. Because of this thick muscles, it keep it round shape like this. But the muscles on the right side are thinner. I'm not saying thin. It's not thin. Atria is thin. This is not thin. It's thinner. So this push on it. The thicker part push on it. So giving you different shape. The shape here is different than the shape here. And these are the three differences between those two. What are these? What is this? What do you call it? It's a weird name, right? Yes. Trabeculae carneae. Trabeculae carneae. How about the ones inside the auricle? The ridge muscles inside the auricle. Pic, pectinate muscles. Just it looks like this, but in the atria we call it pectinate. Here we call it trabeculae carneae. Obviously, when these muscles contract, push the blood, it will look like this, smaller, pushing out. And this is where it's dilated. So it dilates to accommodate and store the blood, and then constrict to push out the blood. We talked about the valves already, and I mentioned what keep it in place, right? What keep the valves working as one-way exits. It is chorda tendini attached to the papillary muscles, right? What if an issue happened to these muscles or the chorda tendini and you cut it somehow, or it lost its job? It will go backward. We call that regurgitation. Regurge.
Like you're throwing like
It should go from right atrium to left atrium to right ventricle only. It go backward. Part of it go backward. This is only if something happened to the chorda tendini or to the papillary muscles. Semilunar valves do the same thing basically, but there is no muscles to reinforce it. If an issue happened to the valves, we call that valvular heart disease. Disease in the valves of the heart. And this uh, will change the valves and they will not do the job. It can happen for different reasons. We're not going into the details, but if something happened to the valves, whether it's happening directly to the valve, like in the semilunar valve, because there is nothing else there, or in the chorda tendini and papillary muscles, there will be an issue with the valve doing its job. Here you have three cusps, one, two, three. So this is the right. This is two. So this is the left. Look at the aortic and look at the pulmonary. How many cusps here? One, two, three. How about this? One, two, three. How about this? One, two, three. All of them have three, except bicuspid. This. All three out of the four. They have three cusps. The only one that have two is the left, which is the mitral. So here is the blood coming oxygenated to the left atrium, passing through the mitral, and look at the chorda tendini and the muscle. It's relaxing, so the blood can go. But when this ventricle contracts, they are going to these muscles are also contracting, so that the blood doesn't go backward. Here it is again, two, three, three, three. But these are open now. So those two open at the same time, and those two open at the same time. They alternate. They do not all the valves open at the same time. Okay? Blood is in the atria. Okay? And it's going to move down to the ventricles. Those two valves will open at the same time. Are we following? Two atria on top, two ventricles at the bottom. There are two valves in between those. One is between right atrium, right ventricle, and one between left atrium, left ventricle, right? Both of them will open at the same time, so blood goes down in the ventricles, both of them at the same time. And then, when the ventricles contract, these two valves will close, right? Otherwise, it will go back. And which ones will open? The exit out of the heart, the semilunar, aortic, and pulmonary. So look how they closed. Look at this. When you contract, the pulmonary open, but the left AV closed because you wanted the blood to leave the heart, go to the aorta. It doesn't go back. And that's why this is closed. Look at this. Compare this. This is relaxing. What's happening here? Notice when these muscles relax, dilate, blood goes into the ventricles coming from the atrium. So this valve is opened and this valve is closed. Filling, 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 filling. This is called dilation. And then when they contract, the opposite now. This close and the aortic open. Same thing on the other side. Coronary circulation. We have arteries and we have veins. And again, we talked about those in lab, but refresh your information again. Arteries are called coronary arteries, isn't it? How about the veins? What do you, most of them are called? Is it called coronary veins? What is it called? The veins of the heart. What do you call it? Cardiac. Great cardiac, middle cardiac, lesser cardiac, right cardiac. The veins are called cardiac. What's the one huge vein that's not one, only one huge vein that's not called cardiac? Coronary sinus, yes. Coronary sinus. So, one more time, where the coronary arteries, right and left, arise from? What's the origin? Are you following with me? Where do they arise from? Aortic sinus. They start from the aortic sinus. Right and left. Right coronary artery will give you marginal and posterior interventricular. Do you still remember this from the lab? Right, give you marginal, and the rest will go backward and become posterior interventricular. And the left will give you circumflex and anterior interventricular. What feeds what? That can too much. Just generally speaking, let's say the right coronary feed the right side of the heart. This is not perfect, okay, but that's okay. Mainly, the right coronary artery feed the right side, left coronary feed the left side. Okay, there are some exceptions, but that's good enough. There is something called anastomosis that we need to know. It's called arterial anastomosis. What's arterial anastomosis? You probably didn't notice it, but do you remember that interventricular artery in the front, anterior? Do you remember that in the back, posterior? If you follow them, they are connected. There is a connection between them. At the end, if you follow the anterior all the way until the end, you will see it connected. There is a connection between the anterior and posterior. And if you follow the back, the posterior, you will see it connected. This is called anastomosis. Anastomosis. Why do we have anastomosis? Just in case. Just in case. Um, what if the left coronary artery is blocked? The whole left side is going to die? No, not exactly. Some of the blood from the right side will go through the anastomosis and feeds into the posterior interventricular. So you still get some blood. Okay. So if somebody's having like heart attack and an artery is blocked, he still gets some blood. It's not zero. He still gets some blood because of this anastomosis. Okay. Like if you have two containers of water, when one of them goes down too much, the other one will feed into it. This is called the anastomosis. How about the veins? Great cardiac vein. Which artery does it follow? When you see which artery, you say this is great cardiac, the circumflex. Anybody remember from the lab? What is the vein or the great cardiac vein is beside which artery? Where to find it? Yes, the anterior. It's beside the anterior. How about the middle? Beside what? Middle cardiac vein. Where is it? Posterior. It accompanies posterior interventricular. Yes. There is also the small cardiac vein that follow the circumflex and not the circumflex. It follow the right coronary and marginal. So look at these. Which artery is this? Are we looking anterior or posterior? This will help you in the lab. Look at this and tell me. And it's okay to get it wrong. Are you looking at the anterior or the posterior? How did you know? Yes, but look at this. You only see the auricles. Did you notice this? Where are the atria here? Do you see it? You don't see atria. You see the auricles only, right? This is the front. If you see the atria, it's in the back. So this is the front. What do you call this artery? Interventricular. Is that anterior or posterior? Anterior. And what is this? What is this? Right coronary. And what is this at the margin? Marginal. And what is this? Circumflex. And what is this? The left coronary. Now, is this is the front or the back? How did you know? See the atria? Is it clear enough? You see the atria here. So this is the back. This is in between the two ventricles. What do you call it? The artery. It's in between the ventricles, interventricular, anterior or posterior. What's the full name? Posterior interventricular artery. And what's that vein beside it? Middle cardiac vein. Yes, middle cardiac vein. And what do you call this big, large, dilated vein? This coronary sinus. Where does it drain to? Right atrium. Do you remember the opening for coronary sinus and right atrium? This is what opened there. Same thing here. Coronary artery disease, basically, the arteries are diseased. The arteries have an issue. The coronary arteries have an issue. What is that issue? Either it is partially blocked or completely blocked. Is there a difference between those two? Yes. If it is partially blocked, it means blood still go to the muscles of the heart, right? But less. So patients or people will feel like some pain in the heart, okay? And they feel uh, like they are going to faint or something like that. They don't get enough blood, but they still get some blood, okay? And this is not fatal because it goes away. If you just sit down, lay down, don't do any effort, you'll be fine. You need to go to the hospital, but it's not a huge issue. And we call less blood going, we call it ischemia. Ischemia. Isch is a prefix that means less. Emia means blood. So what's ischemia? Deficiency of blood. Yes. Okay, this is injecting some sort of um, radioactive material and they take the pictures from outside. Basically, they can tell if the blood is moving or it stopped at certain point. If stop, there is an issue that need to be solved. Coronary artery disease, something blocking the artery. What is that something? It can be fat, cholesterol accumulating, and in this case, it's not blocking it. It's reducing the flow. But if a blood clot, do you remember when we talked about the blood, the blood clots? Do you remember this? The extrinsic and intrinsic. Do you remember this? Intrinsic, intact, wasn't it? So if the intrinsic happened here, it was triggered, and you get a blood clot inside an intact blood vessel. You don't need it. It will actually circulate and get stuck in one of these arteries. Which one? It depends on which one have more fat. That's why they always tell us you have to measure your cholesterol, you have to measure your fat and all that stuff because fat accumulate inside. So the lumen become narrower. So when this clot circulates, it will find one that's narrow enough to close it. And it get that coronary artery disease. The other thing is, again, I'm not going much into the depth, just to understand the idea. Sometimes the coronary artery simply contract for no reason, spasm. Look at this. Look at how the fats make this lumen smaller. This is normal. Look at this. The fat accumulate and making this smaller. If a blood clot coming here, it will be bludged in here. It will block this. And what do we call fats inside the artery? Plaque or atherosclerosis. This is the medical name, atherosclerosis. Angina pectoris versus heart attack. Is that the same thing? No, it is not. Remember this. Blood feeding the heart itself through the coronary artery, it can be reduced or it can be blocked completely. Aren't these two different things? Right? There is a difference between being thirsty, you're getting some water, but you're still thirsty, and you die from no water, from dehydration. These are two different scenarios, right? So if that coronary artery is getting some spasm, or there is something here that's reducing the flow, is it still moving? Yes, but not enough. The condition here is called angina pectoris. The muscles are not going to die. There is no permanent damage. It's something temporary and should be solved. And we call that angina pectoris. And some people get this and they ignore it like this. Like some people will get, oh, I remember I felt some pain here and it was like coming here and it stayed with me for like 5, 10 minutes and then I was okay. And then what did you do? Nothing. It was okay. It went away. No, this was angina and stayed for some time and then went away. But when it come once, it will come again and it will worsen. The next time can be the same. The next time it can be blocked completely. So at least if this is an angina pectoris, which is temporary, reduction of the blood, reduction only, less blood. Get treatment, you will not get the complete block. What's the complete block? Myocardial infarction or heart attack. Classic definition, infarction. You need to know this. Infarction. What's infarction? Death from block of the blood flow. Zero blood going to this muscle. This muscle died already. This is infarction. Did you get the difference between angina versus myocardial infarction or heart attack? These are two different things. If you get something that's pain and you feel like you're going to faint or something, if you feel something like that, this is not heart attack. This is not heart attack. This is not myocardial infarction. This is just angina. It might lead to, but when you say heart attack, you mean myocardial infarction. And the only thing I want you to know about the infarction is complete block lead to death. It is death. So this is irreversible. It died already. Myocardial infarction. It can be because of any reason, but this is good enough to know. Look at this one, for example. This is anterior interventricular artery. In this case, it's blocked. Look after this, no blood goes. So this area, dead. It's damaged already. So this is actual heart attack, and this is actual myocardial infarction. What if this is just reduction only?
It's just NGO.
Angina, angina pectoris, angina pectoris. So is this area going to die? Is this area going to die? The circle, if there is less blood? No, it's not going to die. Okay, it just,
Only when there's a complete.
yes, only if it is complete, it's going to die, myocardial infarction, heart attack. If there is less blood, it's not going to, it's going to suffer from less oxygen. We call it angina. So here is myocardial infarction. I already told you about it. You don't need to know much. Just understand the idea. Complete block of the blood flow lead to death of this cardiac muscle supplied by this artery. Complete block is the name that you should remember, and death. So where is the death came from? Is it like infection? Is it infarction? I'm talking about infarction. It's death. Can you only say death? No, not enough. You have to say death because of the block of the blood flow specifically, because cardiac muscles can die from other issues like severe infection, accident. It can die. It doesn't count. This is not infarction. Infarction is something very specific. It does not mean death. You have to say the whole thing. It's not death. It is death because of the block of the blood flow. Specifically, there are other reasons. This is not infarction. Any other reason. Toxins, infection, inflammation, accident, injury, it doesn't count. The only thing that counts toward the myocardial infarction is death from complete block of the blood going to that area. Okay. Now, the problem with angina pectoris, I just told you about it. It stays for some time and this goes away, and a lot of people just leave it alone. Yeah, like somebody going to the hospital, and I've seen that before. He's coming with heart attack, and the first question that we ask him, "Did you have issues before in the heart?" No. I mean, I remember like 6 months ago or a year ago, I had this like pain going here, but it goes away. It goes away. It was angina, and you leave it until it's completely blocked. Okay. Now, if it is completely blocked, this part of the muscles are going to die, right? This part that's dying, the contents, the inside of it will be released in the blood, right? If you have a container, these cells are intact and healthy, everything stay inside. The membrane is okay. But if it is dying, whatever was inside will leak outside. Make sense? So we can measure that, and they actually do it. We can measure it in the blood, specifically troponin and CKB, okay, or creatinine phosphate and cardiac troponin. What is this? Why do we measure it? Because if somebody's coming with heart attack, we take a sample of the blood immediately and we give it to the lab as soon as possible. Give us troponin and CK, and let's see. If it is high, it means the muscles are dead and whatever was there leaked into the blood. It will be too high. And they automatically, routinely measure that. Because where did you get it from? No. If part of the heart have this is dying, it doesn't lead to death. The body will replace it with fibrous tissue. So the heart will be weak, but he will not die. Okay? Unless, and this is extremely rare, unless the whole entire heart, it's almost impossible. Like the whole entire heart is muscles are dead. This is too much. 99% of the time, it's not the whole entire heart. It is part of it, part of the right, part of the left, and so on. So, anyways, this is the idea behind this. Why do we measure troponin and CK?
To test to see what's.
To test and see if the muscle's dead or not. If they are healthy, they don't release its contents. When it's dead, It's released. We measure it. It's high myocardial infarction. Plus, of course, there are other things, including the ECG and other things, but this part is specifically important.
So you said if they were high, what would you, what did you say again? That would,
If troponin and CK are high, like immediately when this patient go to the emergency room, immediately we take a blood sample and send it to the lab. They let us know as soon as possible. Okay, it takes like an hour or something for this to complete. But anyway, if they give us the results, troponin is high and CK is high. That's it. It is myocardial infarction. How did you know? Where is that coming from? It's not supposed to be in the blood. It's supposed to be inside the heart. Why is it showing on in the blood? It means that the heart muscles are dead, right?
so then if it's low, then it's just normal.
If it is low, that's normal. Yes. There are risk factors, of course, that can lead to that, including, I think this is common sense, right? Why would somebody get a heart attack or myocardial infarction? We all know, right? Obesity, smoking, hypertension, right? Stress. There is a treatment for that. And I'm not going into the details again. The clinical applications is just to make us understand the depth of this. It's not, we're not going into the details. We're not teaching medicine or cardiology. Okay. So simply there are certain medications that dilate the blood vessels so more blood can come. Some of them will dissolve the blood clot if we catch it early. Some of them will relieve pain because they will have severe pain. Some of them are going to uh, increase or decrease, I mean, the contraction of the muscles. There are other surgeries that can be done. Atherectomy. What's atherectomy? What's atherosclerosis means? Fat in the wall, right? Fat in the wall. Atherosclerosis translation, athero, translation fat. That's it. Athero is fat. Sclerosis, the wall is rigid and thick. Why is it rigid and thick? Because of the fat. This is atherosclerosis. Did you get it? So what's atherectomy? Remove the fat. They can get like an endoscope and they have something like this, like my hand, and go like this and like scratch it and take it out. This is called atherectomy. Or there is a balloon angioblast. They put a catheter through the veins until it reaches the heart, and it can inflate it and dilate uh, the artery. They can also make a graft. Simply, if this is dead, it's blocked, they cut it, and they get one of the veins from the legs, some small vein, and they graft it. Okay, let's stop here. 68, and we will do then the rest next time.